Ron, thanks for the kind invitation. Dr. Hahn, the same. I appreciate the opportunity to speak to your Department of Surgery. And I tried to pick a topic that crossed some multidisciplinary lines, so hopefully you'll find this interesting. I have no disclosures. The goals of this talk are really to provide an overview as to the types and clinical presentations of IVC tumors. I'll discuss, at least in part, the preoperative evaluation, focusing primarily on imaging. I'll review our approach and technique of venous reconstructions at different levels or segments and provide some representative examples, and then review our data and conclude with a few comments about other therapies. So most primary secondary tumors, the vena cava, have advanced local or metastatic disease at the time of diagnosis, which precludes surgical resection. Expected survival without treatment is perhaps a year, but rarely more than 2. But I believe in the last decade, the data have now firmly established the technical feasibility of IVC graft replacement in select patients, so much so that venous reconstruction plays an important role in therapy, in my opinion. Now, these tumors are divided into primary and secondary types. Primary venous leiomyosarcoma is very rare and represents only 2% of all leiomyosarcomas. It usually involves a suprarenal segment, so above the renal veins, in about 40% of patients. It's more common in women, and the median age ranges between 50 and 60 years. Overall, so for all comers, abdominal pain is the most common presenting symptom. The tumors tend to be polypoid or nodular. There's intraluminal growth for most, but they can extend beyond the confines of the vena cava wall, and when large, can be indistinguishable from other retroperitoneal sarcomas. And sadly, distant metastases are present in about half the group at the time diagnosis is made. Now, secondary tumors can be divided into several broad categories, with retroperitoneal sarcomas being primarily leiomyosarcoma and liposarcoma. Liver cancers are either primary or metastatic. It's rare for pancreatic or duodenal cancers to invade the vena cava. And then there's a subset of secondary tumors that involve the vena cava by means of intracaval tumor thrombus, of which renal cell, and in particular clear cell carcinoma, is most common, but we've seen it with a variety of other types as shown here. Now, by definition, what I'll refer to, the suprahepatic caval segment is between the right atrium and the hepatic veins, the suprarenal segment between the hepatic and renal veins, and the infrarenal segment between the renal veins and the iliac vein caval confluence. And the suprarenal segment can be further divided into that area that's behind the liver, which I'll refer to as retrohepatic, and that which is between the caudate lobe veins and the renal veins, which we term infrahepatic. And some surgeons and reports refer to this area around the renal vein as the perirenal segment, much the way we do the aorta. Now, there are several definitions of tumor thrombus. We refer to 4 types based on how far the tumor thrombus extends into the vena cava and whether it's above or below the diaphragm. And the latter are really levels 2, 3, and 4. Now, most patients rarely present with venous obstructive symptoms, but we have seen patients with obstruction of the suprahepatic segment who present with arrhythmias, syncope, and some tumor thromboemboli. We've had patients present with subacute Budd-Chiari syndromes and ascites and pain. I've not seen a patient present with nephrotic syndrome, though it's reported. And for those with tumors in the infrarenal cava, sometimes they'll have lower extremity edema. And when the tumor is large, it usually presents as a pain with a mass and occasionally motor sensory neuropathies if it involves the lumbar plexus. Now, the patients with renal cell cancer and tumor thrombus, microscopic hematuria has been most common in our urology oncologic practice, with flank pain and fever, and gross hematuria, the next most common symptoms. Interestingly, there's an unusual finding of kind of a pigmented lobular density that sits behind the cornea of the eye that Jose Polito, one of our ophthalmologists, tells me is pathognomonic for sarcomatoid renal cell carcinoma, which is a particularly virulent form of that disease. Now, the interest that I have was really instilled by Dave Nagorny, who is my advisor and important mentor for me and one of our senior hepatobiliary surgeons. And early on, we established principles of management in 8 patients in a report in 1993, 6 of whom had retrocaval replacement. We applied those basic principles to 21 additional patients and updated that experience in 2000. And that really helped us define patient selection. We validated the technique of total vascular isolation of the liver and in situ cable reconstruction. We had 2 of 29 deaths, or mortality of about 6.9%, and graft patency was good with only 2 graft occlusions, 1 from recurrent disease over 6 years after implantation. So we continued this experience. And really what we do is we define type and extent of the tumor, the presence or absence of distant metastases, and the degree of venous obstruction in the collateral venous pathways by imaging. Then we assess patient performance status. Our preference is to use the Eastern Cooperative Oncology Work Group status. And then we define patient comorbidities, in particular, whether there's cardiopulmonary, liver, or renal dysfunction. And then the medical oncology and or radiation oncology physicians are very important parts of a multidisciplinary team to determine the role for neoadjuvant therapies. We rely on CT or MR imaging with venous phase. We rarely, if ever, will perform standard venography anymore, and only in the rare case that biopsy is necessary. If patients have lower extremity edema, a history of a thromboembolic problem, a family history of the same, or some underlying thrombophilia, will routinely image the deep veins of lower extremities with ultrasound to look for occult DVT. Now, Zinni, who's a urologist and report in 2008, highlighted some MR imaging data that would help define whether intracaval tumor thrombus invaded the vena cava. And this was primarily based on abnormal signals along either side of the cava wall or size of the vena cava itself or at the renal vein ostia. Our urology group, together with me, looked at clinical radiologic data as well and published that report in 2015. And we found that an anterior posterior diameter of the vena cava at the renal vein ostium that exceeded 24 millimeters in diameter, the occlusion of the renal vein or a right-sided tumor correlated well with IVC invasion. And when we analyzed the probability of IVC invasion, the more of those features that were present, the higher the chances were. And I think this is important data for surgical preparation. And then the impact of vascular margin status was applied to 304 patients who had undergone radical nephrectomy for renal cell cancer, and local recurrence-free, distant metastasis-free, and cancer-specific survival was significantly lower with a positive vascular margin. In fact, so much so that the mortality was increased by 1.5-fold, and this study occurred over a median follow-up of just over 6 years. And the consequences of inadequate resection when there's vascular invasion is key. And this is just an example of a woman who'd been operated on 9 months earlier at another hospital who came to us for consideration of surgery, but she already had recurrent intracaval tumor thrombus, tumor emboli in the pulmonary arteries that were quite extensive, even into the subsegmental branches, and then separate pulmonary metastases, and there's no way that she was operable. Now, when we select patients, there are groups that really shouldn't be treated with aggressive surgery. And this is broadly defined as those with poor cardiopulmonary function or a poor ECOG performance status. So we've operated on only a handful of people with a performance score of 2. Most of them have a performance status score of 0 or 1, and we will not operate on anyone with a score of 3 or 4. Similarly, if they have multicentric or multilobar liver metastases or very large sarcomas that are invading multiple organs and or multiple major arteries or veins, those patients are out of bounds for us. Now, what seemingly is unresectable may prove to be resectable. And I provide this case of a 30-year-old Marine that was told to go to hospice. He came here for assessment, and he had very extensive mediastinal, extrapleural, abdominal, and retroperitoneal germ cell tumor and teratoma. And the issue was, could this be safely resected? And so together with Jan Kasserbauer, one of our ENT colleagues and one of our heart surgeons, we cleared the neck and the mediastinum first. And then Mike Kendrick, who's an HPV surgeon here and now chair of our department, together with Brad Leibovich, the chair of urology, and myself, over 2 separate operations, cleared the retroperitoneum and abdomen, illustrated on the intraoperative photographs. And these are his scans 1 year later. And he went on to have a removal of the retrocrural adenopathy shown here and some axillary disease on both sides. Now, our general principles for tumor resection and cable replacement is we'll offer operation to patients with localized disease, good cardiopulmonary function, performance status. Our preferences for prosthetic conduits, and we'll give intraoperative low-dose heparin, usually in the range of 1,000 to 2,000 units, depending on the amount of blood loss at the time the cava needs to be replaced and whether or not there's major liver resection together with the tumor. And then we do selective postoperative anticoagulation, usually warfarin and baby aspirin, targeting an INR of about 2 for 6 months, depending on how that follow-up looks as it relates to the graft. Our preference for prosthetic is externally supported PTFE. These grafts are readily available. The rings resist visceral compression. They're hampered by a diameter of about 20 millimeters, and they're stiff grafts that are a little difficult to deal with. We've learned to keep the rings close to the anastomoses to avoid stenosis, and I'll show you some examples where I didn't do so well in that regard. And occasionally these grafts will develop a little thin layer of pseudointima. Now, in contrast to my friend Bill Canonis at UCLA, who prefers smaller diameter grafts than native cable diameter, we try and match the size. Our approach is to resect and not replace the infrarenal segment if the vein has been chronically occluded, provided the venous collaterals are not disturbed. We much prefer a patch over a graft whenever possible. We routinely replace the peri and suprarenal segments and reimplant remnant renal veins. And our preference has been for in situ reconstruction of the retrohepatic cava because we believe it has broader applicability, versatility, and similar efficacy as ex situ techniques, and avoids the rare risk of salvage orthotopic liver transplantation. We've not done hypothermic perfusion of the portal vein either. Just a comment about the patch. We use bovine pericardium preferentially now. The length of the patch can easily be measured. We'll patch a defect as wide as 60%, unless it's too long when we would replace the cava. But the diameter of the patch tends to be underestimated. And this is all related to geometry of the cylinder and the circumference of a circle. So it's a simple calculation. If, for example, the native normal cable diameter is 20, we multiply that by pi or 3 times the percent of cable wall to be replaced. So if the cable diameter is 20 and we take away 50% of that wall and we patch it, that's going to leave a diameter of patch of 30 millimeters. And if you can imagine stretching out that defect in the vena cava, schematically shown, it would take on a very wide ovoid shape. Now, I want to make a comment about our approach by our urology oncologist to renal cell cancer, which may be different than that done there. They'll engage the vascular and cardiac surgeon as necessary, particularly when there's level 3 or 4 thrombus. The renal artery is ligated early. They use TEE guidance to determine shrinkage of the thrombus, which may affect upper cable clamp position. And then we have frozen section to determine tumor-free margins. And once the IVC is reconstructed, either by primary closure, patch, or graft, then they'll complete the nodal dissection. And our group averages about 300 radical nephrectomies a year, and very consistently for the past 25 years, about 10 to 15% of those have tumor thrombus at some level. They have not done preoperative renal artery embolization, and in part based on some of the data published previously by the Clinic Cleveland group, where the mortality in the embolized group was significantly higher than the non-embolized group, so much so that multivariable analysis showed a 5-fold greater increase in death with embolization. That group often asks the question, how do we manage bland thrombus that may be associated with the tumor thrombus? And as you can see in this work published by Mike Blute, the former chair of that department, 3/4 of the patients don't need anything done other than cable replacement. And those that need something done, the majority have the IVC chronically occluded by bland thrombus, so it's divided, or a portion of it resected, and vascular stapling device used to transect the vena cava and close it so there's no cul-de-sac. Very few if any, need placement of the intracaval filter. Now, our graft configurations vary. That's one of the great things about being a vascular surgeon. We're kind of a fancy plumber. We can design things in many ways. But if we reimplant veins, whether it be hepatic or renal, or we reconstruct one of those veins with interposition grafts, it's important to cut a button out of this very stiff graft to avoid an elliptical anastomosis. You want that to be circular. Choice of incision is really based on 4 factors: the size and location of the tumor, the body habitus and size of the patient, whether or not the costal flare is wide or narrowed, and whether cardiopulmonary bypass is necessary. I would say most often these operations are done through midline or subcostal incisions, which can always be extended into the chest if bypass is necessary. We've done 8 or 9 patients through an 8th or 9th interspace right thoracoabdominal incision because the tumors were just so large. Now, I want to begin caudally and work cephalad as it relates to exposure with a representative case example. Invariably, isolation of the lower cable and the cable confluence requires mobilization of the infrarenal aorta and proximal common iliac arteries. There's almost 1 or more lumbar vein branches that may have to be ligated. The right iliolumbar vein branch is very constant, rises posterior just below the L5 vertebral level. And when I divide these, I'll oversow those branches on the vena cava as shown on the inset picture, usually with a fluoroproline suture that's taken behind the vein and comes across at that branch vein cable confluence. And then on the front side of the vein, you can divide the vein at that point and then just secure the ligature. And on the underside of the vena cava, venous anatomy is highly variable, but there can be some thin, broad, and very fragile vein branches that will cause troublesome bleeding when you're mobilizing the backside of the upper common iliac veins or the backside of the cable confluence. And this is an example of a gentleman that had both an IVC and infrarenal graft replacement. Interestingly, at age 82, he came back. His vena cava graft was patent. The artery graft had occluded. He had developed a urothelial cancer and refused treatment. Now, if we move up to the suprarenal vena cava, that can be approached anteriorly or with full mobilization of the liver and the right lobe of the liver rotated medially. With the anterior approach, 1 or more caudate lobe veins have to be ligated and divided. Occasionally, there's a very broad branch that is best treated with a vascular stapler if you can fit the stapler around it. And this is an example of a 55-year-old man who had renal cell cancer, level 4 thrombus, and it proved to be invasive. And he was replaced with a vena cava graft, and the remnant left renal vein was reattached. Now, I point out that if you notice the upper probably 2.5 centimeters of that graft has no supporting rings. I learned a tough lesson because he came back with a stenosis and some lower extremity swelling, and fortunately could be treated with a venous stent. Now, this is a 66-year-old woman that was recently treated with a suprarenal lelomyosarcoma. These are often infiltrative, and in fact, this one had infiltrated the left lobe of the liver well into the right renal vein towards the hilum, and in the medial left renal vein, and included the left renal vein. So the collateral branches of the left renal vein were well developed. And this patient underwent graft replacement, a left hepatectomy, nephrectomy, but the left renal vein was not reconstructed. Now, a few comments about total vascular isolation of liver and retrohepatic IVC replacement, whether or not a concomitant major liver resection is performed. So the tenets are outlined here. You need to have a secure place for the suprahepatic clamp because once the vena cava is divided, it tends to retract. And I first learned this lesson when I didn't pick a good clamp and the doggone vein started to slip through it. Heart rate increases in that circumstance. Now, we'll sometimes secure that position right at the diaphragm or even just immediately above the diaphragm in an extrapericardial position. We'll test clamp the suprahepatic vena cava to determine hemodynamic response. And generally, if the systolic blood pressure can be maintained above 100, it'll be safe to clamp without the need for venous bypass. We will not test clamp the suprahepatic cava in those that have tumor thrombus, though, that's nearby. And in those cases, clamps are solely and sequentially applied to the lower cava, the renal veins, and the portal triad. and we allow the anesthesiologist to give fluid and or some low dose pressure to adjust hemodynamics. But once the upper anastomosis is completed, the clamp and the portal triad is released to wash out acid metabolites from the liver. And then with the patient head down and lungs inflated at 30 millimeters of mercury, we flash the upper clamp and then transfer it onto the graft. And my preference now is for a Fogarty Hydrogrip clamp because it seals these rings nicely. The second key area, once you're dealing with the lower anastomosis, besides some of the vein retracting, is that it's easy to cut the graft too long. So we have the anesthesiologist give a maximum breath and then a maximum inhalation, exhalation. Whatever I think I'm going to cut the graft to the length, I always cut an additional 2 or 3 rings more. Ischemic preconditioning is used by Dr. Nagorny when we're doing liver resection and sometimes when the liver is congested. And this is just an example who had a retrohepatic cable replacement because of a renal cell cancer metastasis that was near the renal vein and tumor thrombus. And you can see the graft was beveled along the remnant left hepatic vein, and a short end position graft was placed to the left renal vein. This is an example or another example of a woman with a retrohepatic IVC leiomyosarcoma that extended from the hepatic veins to the right renal vein. There was some non-occlusive bland thrombus below the tumor, and her performance status was excellent. And you'll note that she had a retrohepatic left renal vein. And so this is just a picture of the completed reconstruction. And this was done with ischemic preconditioning of the liver and veno-venous bypass, but only a small rim of liver tissue was removed with the specimen, as shown here. And this tumor had all intraluminal growth. Cardiopulmonary bypass is rarely used, but classically for people that have intraatrial extension of tumor thrombus, and or if there's a retrohepatic tumor that's obstructing the hepatic veins and there's liver congestion. So I'll just show a couple of examples. This is a case of a 50-year-old woman with a history of congestive failure that had a complex iatrogenically induced right pelvic AVM, high flow, and an intracaval mass that was free floating all the way into the through the tricuspid valve into the right heart. Now, her original operation was done in another hospital. She was found to have a low-grade smooth cell tumor, and they got into so much hemorrhage that they put a lot of sutures in place, and that led to the development of the AVM. And when they tried to treat it, they gave her a lumbar plexus injury. Now, fortunately, when she came to us, she had neurologically recovered, but the challenge was how do you do this, and how do you deal with a high-flow AVM? Because vessels are dilated. So this was done with cardiopulmonary bypass. And we made 2 cavotomies and 1 atriotomy. So we made 1 cable opening across the renal vein confluences and another from the lower IVC confluence across the common hepatic vein bifurcation. And that allowed us to remove the specimen shown here, close the cavotomy, start to rewarm and establish blood flow to the major organs. And then I could oversew the base of that internal iliac vein where the nidus of tumor had started. And fortunately, she did well, although she came back later and required a venous stent in the right common iliac vein. Things can get more complex, so it's interesting when you try and define or establish principles of management and then you achieve certain results, sometimes you begin to extend the limits of the reconstructions to see what can be safely done. This is an example of a very healthy 78-year-old woman, despite her tumor, that had involvement of her tumor in the right renal and hepatic veins. And we were able to create a common confluence of the hepatic veins and lay that onto the cable graft with a liver antecedent. And it's sort of laid elliptically around the graft. And then we drop that back down and sew the upper and lower anastomoses and reattach the right renal vein, as schematically shown here. And this is a patient that presented with a subacute Chiari syndrome, had liver congestion. So she was treated with bypass and cooling. And she actually proved to have thrombus inside some of the primary and secondary hepatic vein branches. So with use of a Schnitt clamp, a little Fogarty catheter, and squeezing the liver, we tried to extract as much bland thrombus as we could. And we put the left and middle hepatic veins on as a cuff, and then looked at where the right hepatic vein orifice was and reattached it. And you'll notice that the hepatic veins don't come off linearly on the IVC. And then this was dropped in place and the cable and graft anastomosis completed. Now, the analysis of outcomes is difficult because it involves a variety of malignancies. We don't often have stage. Tumor biology varies from one patient to the next. And most reports lump together primary and patch closures with graft replacement. And I would firmly argue that the physiologic and hemodynamic stresses differ between those that need retrohepatic cable replacement with or without a major liver resection, and those that just need replacement of the infrarenal segment. So let me review our data. This extends from 1990 to 2015. We've currently done 153 grafts through the end of 2020, and during the same time period, more than 3,500 patients were treated at Mayo by our surgical oncology teams for retroperitoneal malignancies, and well more, we doubled the number of patches and primary closures of the cava. But this analysis represents 124 patients, a little over half were female. The mean age was about 55. Performance status was excellent and over 90%. Median clinical follow-up was 34 months, and we had imaging follow-up in 85% of the group. Abdominal pain was the most common presenting symptom, followed by fatigue and lower extremity edema, but 30 patients were asymptomatic and were just found to have a mass on a routine examination. And about 30 patients each had neoadjuvant radiation and chemotherapy, and most patients presented with more than one symptom. Now, a third of the group, or 41 patients, had primary leiomyosarcomas, and the others had secondary tumors, of which renal, adrenocortical, retroperitoneal sarcoma, and primary metastatic liver tumors comprised the majority of that group. 120 patients had PTFE grafts placed. Dave Nagorny created 2 bovine pericardial tube grafts when I was out of town. And then we used a cryopreserved thoracic aortic graft in one patient that required concomitant intestinal resection. I much prefer cryopreserved artery allograft over cryopreserved vein because it has greater tensile strength. And early in our experience, I did one femoral vein panel graft as schematically shown there. 21 patients had renal vein reimplantation. Another 10 had interposition grafts placed to either the right or left renal vein or both. 4 patients had hepatic vein or reimplantation, and in 37 others, we incorporated the remnant hepatic vein in the upper cable anastomosis. Total vascular isolation of the liver was done in 20, of which about half needed veno-venous bypass hemodynamic support. 8 patients have had cardiopulmonary bypass. Surgeons often ask, do you place an arteriovenous fistula? And the answer is no. We did it for 3 patients. The first 3 I ever did, where I replaced the infrarenal segment based on Edward Kiefer's data, but we no longer do that. And our group has had an interest in intraoperative radiation following external beam in select patients, and that was done in 21 patients. And you can see 101 of the 124 had resection of adjacent organs, most often the kidney, liver, or adrenal gland. Multiple segments were replaced in 34, isolated segments in 90. We had 5 procedure-related deaths. 2 were intraoperative. One happened very early in the experience with a large central tumor that involved the suprarenal cava. And at that time, anyway, we had no business being there. It was a mistake in clinical judgment. Another died from intraoperative coagulopathy that had retrohepatic cable replacement and major liver resection. We had a patient die at 8 days from sepsis, another at 70 days from liver failure. And the mistake in that patient, who also needed a concomitant portal vein reconstruction, is that all the preoperative assessments underestimated the amount of fatty infiltration in the liver remnant. And then the last patient died at 120 days from multi-system organ failure, and I included her because she was only out of the hospital twice, only for a short time, but she developed leaks from her bowel related to radiation therapy, eventually infected the graft, and it occluded, and then she died. We've had 9 graft occlusions, 1 early at 18 days, 8 late at a mean time of 30 months from surgery. We've had 3 graft stenoses, 2 prosthetic, 1 panel vein graft, and 2 of the 3 were treated with venous stents. And of the 2 graft infections, both patients that I treated, they led to graft occlusion. Now, this light table analysis does not include the 95% confidence intervals, but I tried to put something on a single slide. Graft patency has really been excellent at 5 years at 88%. Overall survival is 52% at 5 years, and progression-free survival is 32%, but local control disease has been very good, with a local progression-free survival of 66% at 5 years. And if we look at the more contemporary series, you can see that our mortality compares quite favorably to the experience reported by Alan Henning and his team and Bill Canonis. And if we look at survival for primary and secondary malignancies, it ranges somewhere between about 40 and 50% roughly for these malignancies. In our experience, I've already detailed the progression, local progression-free survivals. I just want to provide some more recent data as it relates to prognostic factors for some of the primary and secondary tumors. And this is some data published by Heather Wachter and colleagues from Penn, where they found poor overall survival in a pooled analysis of 377 cases of primary leiomyosarcoma vena cava if there was incomplete resection or resection of multiple adjacent organs. And survival was best if the tumor is isolated to the intrahepatic segment, not involving adjacent organs. And then they looked at risk factors that lowered disease-free and overall survival. These were based on tumor size, adjuvant therapy, whether or not the cava was replaced, the location of the tumor in the cava, and the overall survival group, age over 55 years. And disease-free survival was impacted or worsened the more of these factors that were present. Now, the most recent multi-center experience for treatment of renal cell cancer with tumor thrombus going above the diaphragm is shown here. And it includes data from our urology group. The cohort was 162 patients. Cardiopulmonary bypass was used in about 37%. They examined 90-day mortality rather than 30-day mortality, and that proved to be 10.5%. And on multivariable analysis, mortality was influenced by performance status and preoperative serum albumin levels, and major complications by performance status and the level of the thrombus. And if we look at outcomes of nephrectomy and IVC tumor thrombectomy over the last 10, 15 years or so, it's really pretty reasonable, provided there's no metastases, with mortalities reported between 40 and 71%. But once metastases occur, survival is significantly lowered. And then when there's been numerous assessments of prognostic factors for renal cell cancer and venous tumor thrombus, with the presence of distant metastases and sarcomatoid features having the highest hazard ratios. And when they looked at predictors of disease-specific survival, the biologic behavior of the tumor thrombus rather than its level, the number of the time to metastases, and whether or not immunotherapy had been given were the primary predictors. Now, I'm going to conclude with two comments about pre- and intraoperative therapies. In our practice, there are select patients that have external beam and intraoperative therapy, and data reported by Ivy Peterson and her team, and that's been successful. Our oncologists have favored targeted molecular therapies and tyrosine kinase inhibitors in some individuals, but for those that receive tyrosine kinase inhibitors, most of the data suggests it can reduce the size of the primary cancer and its metastases in some, but there's little data that shows a definite impact on making tumor thrombus significantly shrink. And then my final comment is just to provide a summary of the Strauss phase 3 clinical trial that was multi-center in 13 countries. This compared preoperative radiotherapy plus surgery in one group compared to surgery alone in the other group. Patients had to be considered operable and to be candidates for radiation therapy. They had to have a performance status score and an ASA score of 2. 266 patients were enrolled, evenly divided between the two groups. In the radiation surgical arm, 119 came to full treatment, and 128 of the 133 came to surgery in that arm. The primary endpoint was abdominal recurrence-free survival, and that proved to be a composite endpoint of progressive disease, ASA scores that got to be 3 or worse during radiation treatment, macroscopic disease left behind, sarcomatosis, and local relapse. But when they examined median abdominal recurrence-free survival, there's really no difference between the two groups. And the authors concluded that preoperative radiotherapy should not be considered standard of care. Now, one of the limitations of the study is that it was not histiotype specific, and there were more patients with liposarcoma. And interestingly, the low-grade liposarcomas on separate analysis seem to benefit to some extent from the preoperative therapy. Now, there's going to be a subsequent trial examining the role for neoadjuvant chemotherapy with doxorubicin combined with another agent. I talked to our sarcoma oncology group, and they are not going to participate because they believe in chemotherapy in those patients. So in summary, primary and secondary malignancies of the vena cava can be safely resected in select patients. I think the keys to success are patient selection, the right surgical and oncologic team, and you have to be able to execute the operation. Surgery currently provides the best chance for survival, and this may all change as effective as neoadjuvant or adjuvant therapies are developed. Thank you so much for the opportunity to speak to your very prestigious group, and I'm happy to answer questions.